All right, mic check, check, check. Everybody hear me out there in TV world? Colton, can you guys hear me? No? Denver has their puppy again. That's cool. No, it's like some kind of Siberian husky dog sled training kind of dog with a ball. All right. How's everybody doing today? You guys awake? No, no one even. Alan, are you awake? No. Yeah, that's good. I think my performance is always better in front of a bunch of sleepy residents than like wide awake, fresh students that want to learn really badly. So today we're going to start the second lecture in this vascular procedure lecture series. It's going to kind of continue on from what we did 2 weeks ago, but it'll cover a few different topics. I'm pretty sure we're going to get out early today, as long as the questions are held to a minimum, which is always a problem. And the reason why I'm letting y'all out is because I want to be rated the top favorite instructor at Wesleyan, you know, so I'll do what I have to do to make that happen. So, all right, so lecture 2, we're going to talk about lower extremity revascularization, transjugular interhepatic portosystemic shunt procedure, aka TIPS. That'll probably be the last time you ever hear me say that long, mouthy word sentence again. Pulmonary embolisms, peripheral vascular access, and then IVC filters. The learning objectives are the same, kind of a carryover from the first week, since these are one lecture split into 2 because it's such a large volume. I'll give you 2 seconds to kind of glance over those, and then we'll get into it. So once again, with this lecture, I didn't include all the videos. I think there's less videos, and then I didn't include some of the pictures because I wanted some decent shock value to make sure you guys were awake. But if you want these, just email me and I'll send them to you. They're not necessary for testing purposes. So, okay, so we're going to start off with lower extremity revascularization. So this is awesome, right? Who just had lunch? Oh, Suzanne's eating lunch. Okay, perfect. So we get these toes several times a week where I work at, early in the morning with one surgeon. He always wants to cut at 7. He'll lop these off, and then he'll go about his day of like healing other foot ulcers and whatnot. But we see these often. They're nice. They're not hard anesthetics. As you can imagine, there's very little feeling left in this lower extremity. But the primary reason why we try to do revascularization in these people is that we want to make them have a better life. So there's a recurrent theme throughout this lecture. If they don't necessarily look like they're going to have a better life by us reconnecting some veins or doing a bypass, we may opt to do the amputation in order to help them further along. So there is some upper extremity clotting, but it's not nearly as popular as the lower extremity. And I'm sure that has something to do with the different pressures between the upper and the lower body. So peripheral arterial disease, this affects more than 80 million adults that we're aware of, okay? It has killed, or is responsible for over 17 million deaths a year. It just recently overtook communicable diseases. So we started placing our pleasure in other areas like fried foods, burgers, pizza, beer, smoking. So that's kind of sad to me, but whatever. Arteriosclerosis is the most primary cause pathophysic mechanism for coronary artery disease. And this, I wanted to give you a proper definition. So it is a generalized inflammatory disorder of the atrial tree, which doesn't make any sense to me, right? So I went a little deeper, and it deals with the definition that you guys are probably more familiar with, where there's endothelial damage, there's shear stress, inflammation, destruction of the LDLs, and that kind of creates the plaque that we're so used to seeing inside people's vasculature when we cut them open. So this, if you get diagnosed with this, it's very serious, because most people think they have to worry about losing a toe or a blow in the amputation, but this patient population is more likely to lose their life than an extremity. So it's a very serious disease. This is the primary risk factors, goes along with every other primary risk factor we've seen through this lecture series. The one thing I'll mention is that the smoking plays a huge role with arteriosclerosis, and it's taken very seriously. I've been involved in at least 2 cases where the vascular surgeon canceled the case in pre-op because his patient smelled like smoke. And this particular surgeon has a deal where he puts him on a cessation program. He wants him to quit for good. They counsel him, they give him therapy, they give him medicine. They want him to quit smoking because his work will be for naught if he does a graft and this patient keeps smoking, right? So he's even fired patients from his service because they couldn't stop smoking. As I mentioned before, most of these patients are asymptomatic. Therefore, we don't know the true prevalence of how bad this disease is, right? We know it's out there, but until people come to the doctor to talk about this weird pain they're having in their calf, and whenever I think, this is silly of me, but every time I think of PAD, I always think of calves, like calf cramps and stuff. Maybe that's because I've had a few of those in the past. But so they don't come and seek treatment until it's kind of far along, right? Because it doesn't really bother them. We create collateral circulation around the blockage to keep feeding blood to that muscle tissue system, and so it's not bad until it's bad. Claudication is pain caused by too little blood flow to the tissue area. It's usually seen with exercise. So intermittent claudication is pain caused with activity in a specific muscle group that is relieved when they sit back down on the couch, pull out their popcorn, and watch Magnum PI. Anybody know what that show is? Yeah? Okay, some of the more like mature people in the room knew what that was. No, not at all. I mean, you're the only one that said yes, but... so the symptoms for intermittent claudication depend on where the clot's at, obviously. And as I just mentioned, there's a lot of collateral circulation initially built around these clots to kind of protect the body. That's one of our body's auto mechanisms to protect ourselves. So intermittent claudication is usually the very first most common sign we see for PAD. And it's defined as a reproducible discomfort in a defined muscle group that is induced with activity and relieved with rest. Critical limb ischemia takes it to the next level. 25% of these patients will end up with amputations. And this happens when not even the most basic metabolic needs can be met in these muscle tissues. This results in rest pain. If you have a patient in pre-op holding that has rest pain, then you know that they're really far along in this disease process. The majority of the emboli that's causing these blockages come from our heart, and then they travel downward. You'll see it commonly in people with AFib or a recent massive MI or something like that. Those are the most common causes. Has anyone been called to like a code leg response or anything like that? Do you guys know about that? So you know, like when you get a patient in the ER and they're having a heart attack, the cath lab has a rule where they have to have them on the table within 30 minutes of arriving to the ER in order to save the most tissue and get rid of the clot and all that. Well, at all things they have a cold leg team, and it kind of is the same thing. They have to be on the table within 30 minutes of that patient getting to the ER. If this goes on longer than 6 hours, we'll have irreversible tissue damage. And so they take it very seriously, especially if the patient comes in saying, you know what, an hour ago I felt totally normal, and now my leg is blue and it's super cold. You know, that's like, all right, emergency, hit the button. We'll do medical treatment first. Stop smoking. So when we tell people to stop smoking, and I'm guilty of this myself, the first thing I think about is that I'm trying to prevent them from getting what? Anybody? Lung cancer. Thank you. Thank you. You get an extra point on your test. I'll talk to Schaefer about that. I don't know if I can pull that off. Yeah, so we always think about lung disease, right? Lung cancer, stop smoking. But the reality is that smoking causes arteriosclerotic disease so much more than it does lung cancer. And now we have to worry about vaping, which I don't know if there's been any relation to that in any of the disease processes we're talking about today. Medical treatment includes normalizing the blood sugar, treat hypertension. Now, the two textbooks that I like to use for creating lectures are at opposite ends of the spectrum on what to do with beta blockers for these patients. One of the textbooks says, do not start them on beta blockers because you're going to give them a heart attack intraoperatively. The other textbook says, start them on beta blockers to prevent an intraoperative heart attack. So what I say, and will be on the test, is if they come to you on long-term beta blocker therapy, continue it. If they haven't taken a dose that day, give them one in pre-op holding or give them one in the OR. Do not start them on a new beta blocker regimen that day. That is tied to increased mortality. Do not stop their beta blocker on the same day of surgery because that's also tied to increased mortality. If they come in with hypertension and you don't want to start beta blocker therapy on them, you can look at ACE inhibitors, calcium channel blockers. Both of these will help also with the pain because they'll help dilate the vasculature below the clot, feeding more blood to that area. Of course, we're going to want to get them their lipids taken care of because that plays a big culprit in arteriosclerosis. I already mentioned if the surgeon comes in and sees this patient and he just knows that this is going to be one of those deals where it's surgery after surgery after surgery, this guy's life's not going to get that much better. They're literally going to suggest chopping off the leg instead of putting the patient and the anesthesia people and the surgeon through all this pain. Things we can do to help them before we get to that point is doing angioplasty, put a stent in place. An in situ bypass is where we use our own veins. Synthetic bypass is where you see the big grafts. And then a lumbar sympathectomy. I haven't ever taken part in one of these, but what this is where they chemically destroy the nerve bundle near the ischemic region to stop the pain. This is only done in very serious megaspasm, consistent, constant, everyday, painful, I can't live spasm kind of things. It sounds like a good idea. The research out there says that it's more often than not an incomplete destruction of that nerve. So they do get rid of some of the pain. It helps with venous capacitance, but they don't usually get rid of all the pain. But I guess getting rid of some is better than none. And then here's the ironic part about this. For these lumbar sympathectomies, there's often nerve regeneration where they try to ablate the nerve, which it's ironic to me because we're trying to do all this spinal cord therapy, these paraplegics, hemiplegics, and we can't figure out how to regrow those nerves. But here we're trying to destroy a nerve, and it's like Mighty Mouse, and it's like it comes back, right? So I don't know. That's not, I guess, not funny, but ironic. Anyway, so they can also lose motor pain for up to about 2 weeks, but that usually returns. So the idea is zap the nerve, get rid of the pain, keep the motor intact, so their lifestyle stays pretty high. Endovascular therapy, several options here. Most of them include some kind of balloon therapy, angioplasty, or a stent. Very successful locations are the iliac arteries. And then the femoral popliteal arteries have a less success. We see them come back because of emboli in their grafts, or in their stents, whichever one they have. So those come back more often. All of these therapies are temporary. They're fixing a symptom. They're not curing the disease, right? The disease is arteriosclerosis. Interestingly, the further we go up in the body, the further cephalad we go, the less blockages occur in these therapies. Big operative procedures, endarterectomy, like I talked about with the carotid last week, where they slice open the artery, clean out the plaque, and close it. Arterial reconstruction, we touched on that a little bit. Bypass grafting, and then finally amputation. As I mentioned, if any of these patients come to you with a cold leg, if it's not treated within 6 hours, that tissue is going to be gone forever. So not only when you meet them in the ER or when they come up to the OR holding, you have to find out, which hopefully the ER docs would have asked them this question, but you have to find out how long ago did this happen? Did it happen and then you came directly to us? Did it happen at lunchtime and you tried to work through it 3 hours ago and then came, so depending on that, you may move up the case. The surgeon may move up the case. The surgeon always thinks, their case is the most important, so that's a common deal we deal with. In situ bypass, commonly only done from the femoral popliteal or the femoral tibial. Those are smaller vessels, and we typically use the saphenous vein. These can be very time-consuming procedures and super painful both to you guys and the patient. So what they do here is they harvest the saphenous vein, and if the surgeon doesn't know how to use the endoscope, how many of you guys seen them harvest the vein with the endoscope? That's a super cool deal. They put a little incision in the thigh, then they have this camera that goes in, they cut off all the collaterals as they follow the vein down the leg. Small incision. If the surgeon doesn't know how to do that, he's going to go old school and cut them from inner thigh down to ankle. How many of y'all seen that in the units? Is that out of vogue? Jose seen it? Well, when I first started working, that was how they would come out of the OR. Their leg would be wrapped with the ACE bandage from top hip to the ankle, and for days they would complain about that pain way more than the sternal incision. So the endoscope is very helpful, and it only allows for a couple of small incisions, so it's very nice to these patients. Okay, so here's a question. When we use the saphenous vein, but the surgeons invert it before they sew in the transplant. Why would they invert the saphenous vein on a fem-pop or a fem-tib? Right. Saphenous veins have valves, okay? They're one-way valves that lead blood back to the heart. So if we put that in one of our graft areas, then the atrial blood that's trying to go away from the heart would be locked in there. So we have to invert it so it can travel in the way with the valves. Also, you'll see in between each valve there's a little space. Within that space, during systole or the systolic phase, blood will get trapped in there. And then when we have more squeeze, more volume will leave all those spaces traveling forward. So it actually benefits the patient, giving them more forward flow when we use these. I've been doing this, I think I saw an article from the early 70s, so it's been around for quite some time. Synthetic grafts are for the big daddy cases. Has anyone in here done an axillobifemoral? That's what this picture is depicting. I love medicine. I say this all the time. I sound like a dork, I'm sure. But so what this is a graft that's connecting to this patient's axillary takeoff on the right side. They tie it down to his right femoral artery. Then they put another graft from one fem to the other fem. So this axillary artery is feeding both lower extremities, traveling through this graft. It's very bloody. It takes forever, but it's really awesome. Yeah, it's cool. 3 weeks ago, I think I was doing a carotid, and you remember when I last lectured, I drew you guys that stick picture I drew, and then my friend down the hall that wants to be a teacher, she drew this really elaborate aortic arch and labeled all the vessels, and I want to teach, and I was like, oh my god, I just drew this for my student that looks like a stick figure, and she did this. Well, I mentioned she was in a case where she was doing a patient who had a failed, I think they had a failed carotid to fem-fem, and so they were going back and they were doing like a carotid to carotid graft down to the other's fem. I think that's right. But anyway, it was really strange. I don't know the patient's outcome, but if I had to bet $1 on it, I would say it wasn't very positive. So, but we'll get into those grafts here in a second. This is a very slow progressing disease process. That's why we don't know a lot about it until it gets really bad. So most of the surgery is considered elective until we meet some of these considerations here. So if the patient has failed medical therapy, we'll do surgery on them. If they have a loss of function or a gigantic change in quality of life, we'll think about doing surgery on them. And so this is where the surgeon will have to use his brain power to decide, which it's hard for them. I'm sorry, hold on. Disclaimer. Anyone married? Did I do this last time? Okay, cool. And everyone got their hand. Okay. They have to use their brain power because loss of function and quality of life are different for everybody. Like, I'll use my dad, for instance. He just turned 70. In April he'll turn 70. He is a computer freak. He plays video games for 13 hours a day. Like, he doesn't wake up till noon, and he plays till like 2 or 3 in the morning. He has his computer room with 4 computers with Star Wars figures painted on the wall. I mean, it's crazy. But, for instance, if he were to have mild disease, his life isn't going to be that affected because unless it's in his arms and fingers where he's moving the controllers and stuff, so he may not be a great candidate for surgery. It's not going to really improve the quality of his life. But then if we take, let's say my sister. If she, no, better not, she might watch this. Okay, so let's just say there's another person that likes to walk their dog 2 or 3 times a week, and they're a lot more active than my father. If they have less disease than my dad, but it's affecting their quality of life, they'll probably get put on a surgical schedule quicker than my father because it doesn't really affect his life. So you got to think about that kind of stuff, or at least the surgeon does. We have 2 types of surgery: anatomic, which is direct reconstruction, and then extra anatomic, which is that big crazy thing I just showed you. The extra anatomic is reserved for patients that are considered high risk, like that patient down the hallway from me, anyone that's had previous abdominal surgery, anyone that's had previously failed grafts, complications of infection. So usually we want to use our own anatomical equipment to create these bypasses just because it's easier on our own body. During a pre-op assessment, how many of you felt a patient's pulses? My other man. Women? No? So I just went to this big conference the other day, and I met with COA, who are our accrediting body, and they're starting to want us to do full H&Ps on patients like nurse practitioners do. And so that may be something we have to deal with coming down the line. But if you're doing some kind of vascular surgical procedure on these people, you're going to want to feel for pulses, just so you know. Right? You're going to want to detect the temperature change between this leg and that leg, or above the knee and below the knee. Do they have rest pain? If they have rest pain, when they sit on the side of the bed and dangle their legs, does it alleviate the pain? Why would it alleviate the pain? Because we're creating hydrostatic pressure. It's allowing blood to go around the clot, right? If they have hair loss on their legs, like you guys remember those cute old men in the ICUs that had really shiny legs, like they went bald on their legs? Oh no, I might have peripheral arterial disease. Anyway, so they probably have peripheral arterial disease. Okay, and of course temperature. Doppler ultrasound, I can say in 15 years I've probably done it 3 times in holding and maybe 5 times in PACU. But you know, that'd be a good thing to measure the different pulses just so you know the difference before and after surgery. And when you're giving a report to the ICU nurse while they're trying to find the pulses, you can say, well, I found it here, very weak, or no pulse at all. And so, and then the angial-brachial index, we'll talk about that on the next slide. And then angiographies are good because it tells the surgeon exactly where the block's at, where to do the bypass. So those are good pre-op assessments. Some of those we do, and then others you just want to get your hands on so you can prepare fully for what type of case you're going to be doing. So this is a really short, kind of corny video about the ankle brachial index. This probably is done at hospitals, but nowhere near the pre-op holding area. So it's probably done in a lab somewhere, or either at the cardiovascular surgeon's office before they come over here. But if you can get your hands on this, it'll tell you a lot about the patient, okay? So the way we get this number is that we divide the ankle systolic blood pressure by the brachial systolic blood pressure. So ankle, brachial. In healthy people, it should be the same. So when you divide that number, it should be like 1, right? If you divide that number and it's less than 1, let's say it's 0.9, that means they have mild disease. They're probably showing you a little intermittent claudication. If you drop it down to 0.5 or less, that means they have severe disease. And then finally, if it gets down to 0.2, it's going to look like those toes. You don't even need to do ABI on these guys. Just say, you're at 0.2. I know, okay? We're going to cut those babies off. So the important thing is that this ABI score, we use it for more than just telling us what the pressure difference is between upper and lower. This is a great indicator for all-cause mortality. So if they come into you with a low ABI score, you may fix them today, but there's a high likelihood that they're not going to make it too much longer because they have that much peripheral arterial disease. So let me play you this short video real quick. Let me turn the sound on real quick, sorry. Come on. All right, let's see if this works. No.
Ankle brachial index, or ABI, is the ratio of the blood pressure at the ankle to the blood pressure in the upper arm or brachial. During a routine physical exam, your doctor may suspect you have peripheral artery disease, or PAD, due to symptoms such as pain in walking or reduced pulse at your ankle. In this case, he or she may recommend you schedule an appointment at a vascular lab to have an ABI test performed. The ABI test combines use of the blood pressure cuff with Doppler ultrasound to determine whether blood flow in your leg arteries may be reduced to atherosclerotic or plaque blockages. Compared to the arm, lower blood pressure in the leg suggests blocked arteries due to PAD. The ABI is calculated by dividing the systolic blood pressure at the ankle by the systolic blood pressure in the arm. The ABI test is a popular tool for the non-invasive assessment of peripheral vascular disease, or PVD. Recently, more advanced methods such as the quantum flow system from Cellular Scientific have gained popularity for PAD testing due to their higher accuracy and more simplicity.
So I've seen this done before, but I've never seen it where they have like 20 blood pressure cuffs on a patient's extremity. But I think in those labs, they get a more accurate idea of where exactly the clot is. So if the pressure is similar on the first cuff on the leg, similar on the second cuff on the leg, and then on the third cuff, it drops precipitously, then we're going to know where that major clot is located. So once again, an abnormal one, if they're at 0.9, mild disease, 0.5, major disease, 0.2, probably pretty stinky. Stay away from it. Anesthetic management for these people, regional versus general. I very rarely do regional except like on those nasty toes, and I don't do that. Just the surgeon will do like an ankle block, which means he'll just infiltrate the ankle with 1,000,000 gallons of lidocaine in no specific place, and then I give them just a little bit of propofol to sleep through it. However, some of these areas would be good for regional. We do give them intraoperative anticoagulation every case, but that's not necessarily going to stop you from doing an epidural. If you can get the epidural in an hour before we anticoagulate them, then it's not a contraindication. There's lots of advantages with these. We don't have to worry about scrambling our patients' eggs. We don't have to worry about taking away their ability to breathe depending on where the epidural is located. We'll get better graft blood flow. Of course, we're going to cover their pain following surgery because they have epidural in place. And then supposedly, it'll decrease the activation of the coagulation system compared to a general anesthetic. Miller, the textbook was very weak on this subject, so I had to go elsewhere. So for most of this stuff, the test questions are going to come from the lecture. Nothing out of the last 3 minutes that I've said will be on the test, though. Or will it? The first line of treatment is usually anticoagulant therapy. Once that fails, that's when we're going to start talking about surgical intervention. So The interesting thing I found is that although regional has listed all these advantages, there are also studies out that show people that receive regional anesthesia for this type of surgery come back quicker with clots in their grafts than those that receive general anesthesia. And the weird thing about that is that someone actually would study something like that. And then the final say-so on these is probably the surgeon, right? If you're working with an old guy that's so used to doing things in a stair-step fashion, I don't want the patient to move, I don't want to hear the patient talk, I want them out, no local, no regional, I want to hurry up, I don't have time for you to do that in pre-op, then we're going to do a general. But the younger guys that are coming out, they realize the benefits to regional anesthesia, and they take that into consideration, like, okay, well, my surgical time's going to take this long because they're going to do block and holding, and then they're going to go in there and do an outline. So it's getting easier to do regional just because it's becoming pretty popular lately. For the larger bypasses, I'm going to line them up in case we lose a large amount of blood. And then for the smaller ones, meaning like the AV grafts or the fistula embolectomies, maybe a large bore IV. But if we're doing one of those extra anatomic, super long grafts from the axilla to the femorals, I'm going to line them up for massive blood loss as well. Luckily for us, the cross-clamping in these stage surgeries are a lot less than the cross-clamping we were talking about in thoracic aneurysm and AAA surgery. So we don't have that much of a crazy sway with the patient. I would also put the art line on the opposite side that we're operating on. So if you're putting an AV fistula on the left arm, do not put art line in the left arm. Unless the surgeon's cool and you're playing a joke, So thanks for laughing. That was nice. You guys are great. Okay, some of the bigger cases, pop them tib. Those are a little easier for us. We can usually get away with one IV. These usually take about an hour to an hour 30 minutes, depending on how good the surgeon is. Sometimes we don't have to reverse the heparin. They like the heparin to stay in the blood system to keep it nice and lubricated to go through these grafts for a couple hours. The bigger cases, like the aorta bifem, is very similar to a AAA repair. You'll have a big belly incision. We'll have 2 incisions over the femoral arteries. Obviously, there's a great chance for massive blood loss, so we'll be all typed and crossed. These cases take sometimes hours, so it's pretty common to redose the heparin. And just like I told you guys in the last lecture, you'll check the ACT 3 minutes after heparin, then again 30 minutes later. And that's when you're going to tell the surgeon, hey, my ACT is this, how much more heparin or how much additional heparin do you want? And they'll say, give me another 3,000 because we'll be closing in 10 minutes or something like that. So it's not always, you don't always redose as you did the first one. Now these tools are cool. Do you guys know what those are? You guys have done vascular surgery. I don't even know why I'm up here. So those are tunnelers. The small curved one is for like AV fistulas. That super long one is for the axillobifemoral where you have to travel the entire body. The one in the third one is probably like a fem-pop or a fem-tib, and then the lower one could be like a fem-fem. But anyway, those dilators go underneath the patient's subcutaneous tissue and skin to create a tunnel so that they can feed the graft through that tunnel. Those things are super painful. You can have like train track vital signs on your patient until they do this, and then the patient will sit up on the table. So anytime I see the tunneler coming out, regardless of the size, of course I take into consideration the patient's comorbidities, but I always hit them with another 20 or 30 mg of propofol before they start tunneling. That way you can keep that sympathetic discharge at least kind of decently controlled. Typically these are inserted where the most damage could occur. So if we're doing an axillary to bifemoral, we're going to put it up here by the axillary artery because we can see it and we can control it easy. And I'll show you a video here in a second. Instead of starting here in the flank where there's no major vessels and moving towards the axilla blindly. Now, the funny thing, I'll point this out in the video, but they do it, in my opinion, in my professional opinion, they do it backwards in the video. So they want to go from most dangerous to least dangerous because the final end of that push is done blindly most of the time. Hopefully the surgeon will be smart enough to hold the heparin until the tunneling's done. If he doesn't, then those little subcutaneous arterioles are going to be bleeding like crazy. So this is a video I found on YouTube last year, and it is one of these axillobifemoral cases, and it had massage music in the background. There's no words, but it had what are those little finger symbol things? It's just like, I couldn't do it. So I'm going to narrate it as we go through it. It's relatively short. I do have some subtitles, but so we're not missing sound here. So as I said, they're making an incision right here on the guy's ribs, okay, because they're going to travel to the groin, which is what they're doing here, blindly. So where his hand's at without the dilator is the femoral artery. Watch how it pops through there. That could have been in the artery because he's pushing it pretty blindly, right? On this dilator, they feed the bypass into the dilator, and then they push and pull simultaneously. Now they're going to go up to this patient's axilla and dilate down towards the same flank incision they had where they got the catheter out in the first place, and then pull the graft all the way back up to the axilla, which they did right that time because they started in the axilla where the artery is pumping. Make sure there's no kinks in there, and then here they're about to perform the femoral to femoral bypass, which, there's a femoral on each side, so you just have to be careful when you cross the suprapubic symphysis here, and they'll feed it into there and pull it out. Now I kind of wish I left that music in there. So as you can see here, at the very top of this patient, this is where all the blood flow is going to be coming from to the patient's lower extremities. So they're going to attach this to an artery up here. They fed it all the way down his thorax, and then down here you can see one femoral connection and then another femoral connection. That's crazy, right? What's the thing? Feel the thrill and hear the trill. What is it? Can you imagine a party trick? Hey, come here, feel this. Oh, what the? Anyway, I digress again. So some of our post-op concerns with these patients: sudden loss of pulses, obviously temperature changes, complaints of numbness, paresthesia, or if they can no longer move or feel their leg. Now, for sudden loss of pulses, we check these pulses while the patient's filleted open. We check them pre-graft, we check them post-graft. We close their skin, we check them again. They put the dressings on, they check the pulses distal to the dressings, right? That's when we check multiple times. I'm sure they're feeling the temperature when they're checking the pulses too, but we want to make sure that everything's in working order before we leave the OR, because if they get into the PACU and they complain of severe pain, they're going to be coming directly back to the OR, okay? Cardiac morbidity is the most common cause of death in this population during this surgery. This population has a 10 times higher chance of morbidity caused by MI, 10 times more caused by MI than the regular population out there. So watch for signs of MI. You can see ST segment changes, peaked or depressed T waves. If they're extubated and you're going over there, they start complaining of dyspnea, they go apneic, they grab their chest, they complain about angina, they feel a sudden sense of dread, know that they're having a heart attack. You'll probably go to the cath lab if you've already made it to their PACU and have extubated. So where am I at? All right, let's keep going. Okay, moving on. So liver cirrhosis. On this one, I try to find a super ugly picture to gross you guys out, but I can't just help but every time I look at that, I see a fillet. Does anyone see that? Just missing a little bacon there. So portal hypertension, that's one of the end signs of life for people with end-stage cirrhosis. we see portal hypertension all the time, but we probably don't associate what we're seeing in the OR or in the GI lab with portal hypertension. So hopefully after this lecture, you guys will think about that a lot more. What happens here is the portal blood flow is trying to re-enter the liver, but the liver's clamped down. You get this huge pressure created in a vein. Well, the pressure makes the blood go to the least resisted place. So you see splanchnic bed dilation, and then the blood's going to travel to the azygos and the hemiazygos veins, which we'll talk about in a second. And then once again, our body tries to protect itself by formulating these collateral circulation to prevent all the pressure from backing up. So portal hypertension creates ascites, very painful, and hepatic encephalopathy. So this is the azygos, and that is the hemiazygos. And they travel up alongside the esophagus. And they have a lot of little collaterals coming off them. So if we have blood coming from the portal vein and the hepatic vein system going to the least resistant area, which is this is one of the veins that goes to the hemiazygos, what do you think that's going to create? What is that something that we see on a regular basis in our patients? Yeah? What do we see? What do we do a lot of working in the GI lab with people that have, alcohol cirrhosis? We see a lot of varices. So this portal hypertension forces blood to an area with less resistance, creating these varices that could hemorrhage and kill the patient very quickly, right? So when you see varices in the GI lab, think to yourself, well, the reason why those are there is because his portal vein is occluded, blood's not flowing through, so he has a lot of stuff going on. It's not just these little veins in his throat area, okay? I told you where varices come from. These are seen in 40 to 60% of cirrhotic patients. 24 to 35% of these guys are going to bleed. Of that 35%, 30% are going to be fatal, and then if we can save them, 70% are going to rebleed. Has everyone's seen these, right? Yeah, they look to me like, so the esophagus is this flesh tube, and it looks like someone's laid like a metal worm on it to make the groove come in towards it. You know what I'm talking about? And it just looks like a big long worm on the thing. No. Almost time for a break. Hang in there, guys. We're almost there. So how do we prevent the initial bleed? We decrease portal hypertension. We can do this with calcium channel blockers, ACE inhibitors, beta blockers. We want to dilate those vascular beds in order to allow that blood leave the liver space. We're going to treat the hemorrhage, which is always fun and nasty. And then if we can, we're going to prevent bleeding and recurrence. So non-selective beta blockers that we use for these, propranolol, nailol, these will slow down the heart rate, but they'll also open up the splanchnic bed vasoconstriction, allowing more blood to flow that way instead of the azygos, hemiazygos veins. And it decreases overall vascular resistance, which could be a good thing and a bad thing. So these endoscopic band ligations, to me, are some of the worst surgeries we do to these patients. But I mean, it's life-saving, so I understand why we do it. But so if you haven't done it, what it looks like is like a clear vacuum tube being shoved in someone's esophagus. And when they see the big long worm, they will take a vacuum, put their thumb over a device, and suck a bowl of the varice in there. They'll then turn a knob at the top and send a rubber band over that part of the varice, and they'll go up and down the varices as they need to. So a couple days later, that nasty globular thing that's hanging in the esophagus sheds off and goes into our stomach, and we cannibalize our own nastiness. And hopefully, when it falls off, we don't have an open bleed, right? These are super duper painful to our patients. Most of my GA cases, I get away with just propofol. If it's someone really young and healthy, I may add a little Versed to it, but I hardly ever use narcotics for EGDs, UPCs, colonoscopies. But for these patients, I always try to work in a little bit of pain management because it's terrible following surgery. Sometimes it's immediate. As soon as they wake up, they'll start complaining. So, and unfortunately, these patients are frequent flyers, so they'll get these done quite often. So how do we control the hemorrhage? Who's managed the natriuretide drip in the unit before? Right. This causes vasoconstriction, but at the same time, it opens up the portal pressure system, so it sends blood out in different areas and opens up that portal vein so it doesn't create that much pressure. We just talked about endoscopic banding. Sclerotherapy became popular when people want to get rid of varicose veins in their legs. You know, they go to these big clinics and they shoot a little salt solution in the vein. It causes the vein to collapse on itself, and then it like creates like a sticky mess where no blood can get through. No? But anyway, they do that in the throat too. And sometimes they use epinephrine, okay? So when they do a sclerotherapy, you want to ask them, you know, what's in there besides the salt water? Because if you want to know, is it the pain that's causing this patient's heart rate and blood pressure to go sky high, or is it because they just use a little epinephrine to go in there? We want to replace blood loss with PRBCs. So how are we going to do this? Are we going to just do a propofol infusion? Would you guys rather do a general anesthetic on them? A propofol infusion is kind of a general anesthetic, but whenever I see people that are going to have banding, I want to put ET tube in them. Okay, I want to protect that airway. If they start bleeding, it's going to make that airway much harder to instrument and actually identify structures. They're going to be bleeding everywhere. It's going to become an emergency. Whereas if we intubate them prior, we'll at least take care of them, their airway. Also, keep in mind, as this liver gets bulky with all this blood flow, it's not going to be able to take away the ammonia being built up in the body. So they're going to have encephalopathy, snuffleupagus, right? So they're not going to be totally clear. So are they going to be able, if you do a propofol drip, are they going to be able to lay still? Or are you going to be able to find a sweet spot where they're not sitting here heaving and moving, giving the surgeon a moving target with each breath? Or are they going to get obtunded, and then you're going to have to kick the surgeon out of the way and do an emergency intubation? I just feel like we should kind of do it up front. I have even had cases where we go in not knowing the patient had varices, and the GI guy's like, okay, well, I'm going to band these. And I was like, well, I'm going to switch to an ET tube then. And he'll come out, I'll intubate, we'll go back in, go from there. Things to take into consideration, where's this going to be done at? Our patients at All Saints will come down from the ICU to the GI lab, which I like because I know where everything's at. I have a nice, comfortable drug box. I have my machine. I know where the suction's at. Are you going to do it in the unit where it's going to be kind of crazy, right? Because you don't have an anesthesia machine. Make sure you have your Mapleson transport circuit, suction, everything you need available to you. And then if something goes sideways, you're going to have to send people to run and grab stuff for you. I used to get mad when I first started working as a CRNA at my facility because we had a relationship of, I'm a CRNA, he's a doc, the doc's superior. CRNAs are made to push gas from a stool. Docs are made to do interventions, right? Most of the docs I started with are gone. Now we have an awesome staff. But I would get mad because they call me in at 2 in the morning to help with these varice banding. And I would be like, you're a mighty doctor. Why would you call me in for a 15-minute procedure? You, a doctor, calling me, a nurse. And some of them try to explain that, hey, this can get messy. We could need art lines, we could need extra IVs, we could need a hotline. It could get bad. And so now practicing for quite some time, I'm like, well, that's true, that's very true. Well, after that happened a couple of times, it became a self-confidence booster for me because the anesthesiologist would call me in for this super nasty, could go bad in a matter of seconds, varice banding. As soon as I intubated, he would tap me and say, man, I'm going to go do a pre-op for surgery tomorrow. I'll be right back. And I'm like, so a nurse can do this. Hey, Dr. Shaver. But, a doc is going to go do the pre-op. So not all docs are that way. A lot of them have changed over the years. Like I said, those people are gone. And now I know that happiness is a choice, so I don't get angry anymore. So, okay, with that, let's go on break. We'll continue in 10 minutes. Go do some jumping jacks, push-ups, shoot a Red Bull, a Blue Bull, whatever you guys drink, these Monster X's.
Hey, David and Hollis, can you give me a cup?
go ahead and get started again. We'll try to knock this out in the next 25, 30 minutes. Harlingen, y'all figured it out, huh? I could see you on camera the whole time, so I never knew. And I left my phone in my office, so I couldn't, interrupt class like I'm doing right now. But I'm glad TCU left that technology there so you guys could see this video here. Okay, so we're going to continue on with the treatment for varices. The secondary prophylactic type of treatment is the TIPS procedure. Oh, thank you. The TIPS is one of my favorite surgical procedures of all time. Who's done one? Come on, everyone has to experience this. Holly, you haven't done one? Oh, they always start at 3 or 4 in the afternoon, and they don't finish till 9 or 10 o'clock at night. They're terrible for us, but they're very beneficial to the patient. I'll just show you quickly. This is obviously the big liver. This right here is the hepatic vein, portal vein. This is the shunt. So what this does is the portal vein tries to go to the liver to get filtered. It gets blocked. It goes up this little vein to the azygos and the hemiazygos vein, creating varices. But now we put this shunt right here, so as it meets pressure, the lowest point of resistance will be the shunt. So it'll totally bypass metabolism in the liver and then shoot up through the IVC. Cool? Once again, this is called the transjugular intrahepatic portosystemic shunt, or TIPS. How they do this is they'll do a catheter through the IJ, and it'll traverse down, like I said, the inferior vena cava into one of the hepatic veins, and they'll poke a hole through the hepatic vein and stick it in the portal vein. Then they'll dilate, and then they will release the sheath. This will decompress the portal circulation, allowing for those varices to shrink. Now, this procedure is really good because it also takes away the pain. Okay, these patients are in pain. Have you guys seen the patients with ascites that look like they're about to have triplets, and they get drained like 1.8 liters off one day, and the next morning they look like they're about to deliver twins? So that's very painful. It's squishing all their organs. For those of you that have been pregnant, you probably know what this feels like, but I don't. Anyway, I can just imagine it squeezing organs. It decreases your FRC. You can't take deep breaths because there's a huge ball of fluid sitting in your abdomen. This TIPS procedure decreases, sometimes altogether gets rid of ascites, but it definitely decreases it most of the time. Indications for the TIPS: if they've kind of failed medical therapy, if they're on the transplant list and we need to try to save their vasculature and prevent them from getting varices, and then if they have refractory ascites that just won't go away. But as you can imagine, creating the shunt that diverts blood from the liver could create some problems for us anesthesia providers, right? Our medication sometimes needs to go through the liver to get metabolized to work properly. Other times it needs to go through the liver as a first pass mechanism effect to get activated. And so if we have blood flow avoiding the liver, our drugs are either going to work way too well, like narcotics, or they're not going to work well enough because they're not getting metabolized by the liver. If you need to use a muscle relaxant, I'd use cisatracurium or SUX because they do not rely on the liver whatsoever. Decrease your doses of opioid in these patients or else they won't wake up forever. And also, I talked about the ammonia not being filtered out of the body. That could be a real problem for these patients, and often it is. So this TIPS will actually lend itself to even more lack of ammonia clearance. So you can see even more encephalopathy with this TIPS procedure. I like this slide because it kind of explains everything I'm trying to visualize for you. So this is the catheter coming down from the IJ through the IVC into the hepatic vein. They'll shoot lots and lots of dye. Make sure your patients have decent working kidneys. And they'll just start poking holes once they start seeing where the vasculature is, and they'll poke a wire across. This takes forever. And then once they get across, they'll come over here and dilate, slide the shunt through, and then pop the shunt open. It never goes that quickly. I will want to point out, though, this little EV symbol symbolizes esophageal varices. And you can see blood flow is trying to return to go to the portal vein into the liver, but the pressure's so great over here that it's turning it into a little squiggly worm, right? Lots of turbulence. Those walls of the veins there will dilate super quickly. They're not very strong. But once we get that shunt in, look, the cute little EV's gone away and all the blood's flowing in the proper direction. This can be done with TIVA. I specifically always try to do general. For 2 reasons. One, these take days. I mean, they're doing it kind of blindly. They have dye going in through the vasculature, but they don't always get it right. And 2, if you have a patient with any ascites trying to lay flat on the table and you're just doing a propofol infusion, you're definitely going to sign yourself up for some trouble, whether it be the guppy breathing or the apnea. It's not going to be good. So I want to be ready for when what hits the fan, so I tube these guys. Sometimes, I think most frequently I do put art lines in them. We'll get to that, I think, in a second. Airway. So if they have ascites, I always use rapid sequence intubation because they're considered a full stomach to me. Everything is squished up there, okay? So gastric contents could be flying out at you, decreased motility. So if they have ascites, consider them full stomach. If they've had a recent GI bleed, you're going to want to secure the airway. Once again, what's their level of consciousness? Can they lay on the table even if they don't have ascites and stay still for the surgeon to do his job? These guys will have altered volume status because they have low intravascular proteins. It's all going in the belly. They also can have alcoholic cardiomyopathy, which means that you drink so much, like a lot more than us, and your heart is poisoned by the ethanol in the liquor. And so they could actually have like dilated cardiomyopathy, right-sided heart failure. It always makes a TIPS procedure go easier. I already talked to the point about decreased FRC. They cannot take big, deep breaths. They may have silent aspiration leading to pneumonia. Obviously, their liver's out of whack, so they're going to have coagulation problems, maybe thrombocytopenia. We'll frequently treat these patients that have thrombocytopenia with platelets before surgery, like on the floor as they're about to come down to surgery, and then we'll run some more at the beginning of the surgery in order to kind of make them not bleed so much. And I briefly mentioned the pharmacokinetics, what's going on with this liver disease. Well, we're going to have an increased volume of distribution. So that means there's going to be more drug in the tissue, specifically like the fat or the subcutaneous tissue. So less in the plasma. So less of our drug is going to be working. So with increased free plasma fraction, we're going to have an increased volume of distribution, which, like I just said, the elimination half-life is going to be quicker, and the total plasma concentration is going to be decreased. Sometimes this works to our benefit, depending on the drug, and then sometimes it really hurts us. Protect the airway. I always intubate these guys. I give them an art line. They're poking around in the liver. What can go wrong, right? They're putting holes in very large veins. What can go wrong? Check your chemistry frequently. You want to pay attention specifically to the potassium, other electrolytes because they've been on diuretics. They've had large fluid shifts. You want to see how their gas exchange is going. With depleted glycogen stores, it's not a bad idea to monitor the glucose because the liver's jacked and it's not doing its job very good. And then you want to know urine output. Now remember, you're in the interventional radiology suite. Has anyone been an IR nurse before? Anybody married to an IR nurse? No? Okay. Well, so they're not used to putting in Foleys anymore. Maybe they did when they were on the floor, maybe they did when they're ICU, but they're not, like if you say, hey, I need a Foley for this patient, they're going to be like, why? And you're like, I just need one. If you say it's going to be a long case, which is true, they're going to deny you because the surgeon's going to tell them it's going to only take an hour. So you have to be smart, okay? You have to trick them. You have to say, I need a Foley catheter so I can monitor this patient's cardiac output. Like, oh, okay, we'll do that. So that's really nice. But don't try that till you're a senior, okay? Moving on. I also have those patients typing cross too, okay? Because like I said, things can get bad quickly. Pulmonary embolisms. These are the most deadly form of venous thromboembolic disease known to man. It's the most common preventable cause of death in the hospital. These numbers came out of Miller, and I read an article just yesterday, totally unrelated to this. I think it was in the Costco magazine. Like they're talking about peripheral arterial disease, and they had slightly different numbers than I did, but I mean the numbers were pretty significant, so there was that correlation. But this came from the textbook. But 355,000 diagnosed each year, and nearly 250,000 deaths are caused by this. If we find out someone has a pulmonary embolism, anticoagulation is the first line and preferred treatment. However, we cannot give everyone anticoagulation. Trauma patients, some surgical candidates aren't able to take anticoagulation for different reasons. So we'll use a vena cava filter on those patients. What might we see? Well, these patients are asleep, so we probably won't see sudden dyspnea. We probably won't see difficulty breathing. We won't hear about any kind of pleuritic chest pain. If you're listening with your ear, do you guys have earpieces? Okay, no. So you won't hear rails. They won't have a productive cough at the end of the case, but you may see some blood in your ET tube. Hemoptymus. They may get tachycardic, and they could become febrile. But we know the surgeon on the other side of the drape and the anesthesia people do a lot of things to these patients that can cause tachycardia. So it's kind of hard to decipher what's going on. Why is that patient tachycardic? Most of the time it's because of the surgeon. We have to differentiate a PE against myocardial infarction, pericarditis, congestive heart failure, which a PE can cause all three of those. Pneumonia, pneumothorax, pleuritis, and then a rib fracture. So a PE can mimic almost all of these, at least the pain of a rib fracture, not necessarily the rib fracture itself. So to diagnose, we can do ABGs, but these are non-specific, right? There's a lot going on in this patient that could create arterial hypoxemia. And we, on a daily basis in the OR, create hypocapnia on these patients with our ventilator settings, right? So they have three different types of VQ mismatches that create the arterial hypoxemia in these patients. The first one is locally, the vascular beds are occluded. So the ventilation comes in, but there's nothing to exchange the gas, right? Because it's blocked off. So locally, we're going to create a perfusion ventilation mismatch. As that grows bigger, the lung, in its smart decision-making, is going to divert blood away from that diseased area. In essence, creating a larger ventilation perfusion mismatch because it's diverting healthy blood away from the part that needs it the most. And then finally, if we have a sky-high PA pressure, that's going to shunt blood away from whatever's causing that pressure. So once again, taking blood away from the area that needs it the most. EKG changes may mimic a heart attack. We could see new onset AFib or right bundle branch blocks. We could send a D-dimer. You can expect these patients to have a lot of fibrin degradation products, elevated troponin levels, once again mimicking the MI. Things that help us define definitively that these patients have a PE are the spiral CAT scan and VQ studies. The spiral CAT scan goes around the patient, spirals around the patient, takes lots of images, and then creates an image. It's very specific, okay? If it detects an embolism, which it does 95% of the time, they're not going to work the patient up any longer. They're going to say, you have an embolism, this is our treatment plan. It doesn't do a whole lot of identifying the smaller vessels. The problem with this one is that it does require IV dye, and of course there's radiation, right? So it includes certain patient populations from going in there, including pregnant patients. The VQ study is very cool, and it sounds kind of diabolical because it has two phases. The first phase is we have the patient breathe radioactive material into their lungs, and this shows the ventilation portion. And what it does is they take an X-ray shot over a certain time lapse to see what the lungs look like, and so it'll shade the lungs gray, and you'll kind of see the outline of a full lung. If there's a PE in there, it'll be white. The second part of the VQ study is they'll inject radioactive dye into your vein, let it go to your lungs, and this will tell us the perfusion of your lungs. So we have the ventilation shot and the perfusion shot, and I put those together to see what we get. You can use this technique on pregnant people. It's not a contraindication, but if they've already had the baby, hopefully you're not going to advise them. You might have to, but hopefully someone else has advised them that they're going to have to do some pumping and dumping, okay? You don't want the baby drinking that radioactive material. So this is a picture of both of those studies. On the left-hand side of the screen, the arrow is pointing to this very large clot right here, and it's in the left pulmonary artery. Pretty easy to see, right? Then over here on the VQ study, which I don't know how well this turned out, kind of good. This left side shows kind of healthy lungs. So the ventilation's on the top, that's when they breathe in the radioactive stuff, and then the perfusion's on the bottom, that comes from the dye and the IV. Now if you look over to the right, the ventilation part looks pretty good. Not a whole lot different, but when they look at the perfusion aspect of it, there's a significant difference. And that's highly probable that that patient has a PE somewhere. So spiral CT, VQ study, but the gold standard is the pulmonary angiogram, okay? So the way this works is they thread a wire up through the groin or maybe down through the neck. They inject dye directly into the organ. And so we're looking at a right lung. So this is the entirety of the right lung right here. You can kind of see the outline. Yeah, so that looks like good. So this is the upper right lobe, then the middle lobe, and then all of a sudden in the lower lobe, there's hardly any blood flow at all. So that's indicative of a giant clot, as evidenced by the 6-inch blood clot laying to the right of it, which came from the same patient. So, and that was done with the pulmonary angiogram. Things we can use while we're asleep, or while the patient's asleep, we're awake. TEE. This tells us everything we need to know what's going on with the heart. Is the right atrium getting fluid overloaded because all the blood that's supposed to be going through the pulmonary arteries are backing up into the right ventricle. They can actually detect a pulmonary thrombus. I looked at a lot of pictures and videos to see if I could find one specific to the pulmonary artery, and I saw a lot of blood clots in the heart, but I couldn't find anything specific to the pulmonary artery. CVP, PA lines, that can tell us if we have a sudden pulmonary hypertension crisis, right ventricular dysfunction, still not super good. TEE is really good though. So while they're under anesthesia, how do we know if they have a massive pulmonary embolism? We're not allowed to say, hey, I know we're filleted wide open right now, but I think we're having a pulmonary embolism. I'd like to run a CT, do a spiral scan real quick, and come right back, get the vascular people involved. So you have to use your clinical judgment. Okay, if you have a sudden drop in blood pressure in the absence of bloodletting or magnificent sepsis, hypovolemia, new onset dysrhythmias, and you can't get that blood pressure up, like if it's just stuck there and you're throwing all kinds of things at it, think PE. Okay. The other thing that you'll see and think more quickly about PE is the patient's end-tidal CO2. Okay, it's going to drop precipitously. You'll be over here putting your syringes in the order that your CRNA likes them so they don't get mad at you and give you a good eval. You'll look at your entitled CO2, it'll say 33. Then you'll do this over here for your scenario, you look up and it'll be like 17. And you're like, erroneous, and then you watch it and it'll go 10. And it could even plateau out at 0. You're going to think pulmonary embolus very quickly. So if you have a blood pressure that's hard to treat, or if your end tidal drops quickly because you have a gigantic increase in dead space, think PE. How do we treat it? We heparinize them. We then put them on a Coumadin bridge before we can put them on better medications like Pradaxa, Xarelto. The books aren't sure how long this bridge needs to be. Some do it for 6 weeks, some suggest 6 months. I guess they think the longer the better, which isn't always the case, but they don't know what the proper bridge time is. But just know we go from heparin to Coumadin to Xarelto. Once again, trauma patients and certain surgical patients aren't candidates for these drugs, so we will do the vena cava filter. Now, I'm no scientist, and I didn't say it at the Holiday Inn Express, but I can't wrap my head around this device. This is made up of, it's called spider wire, it's a type of aluminum, titanium something, with springs in it. And so they put it in through the groin, the springs open up and it gets stuck in the vena cava, which is great because it's going to catch all the clots going to the heart, right? But like, if it keeps catching clots and keeps catching clots, it seems to me that it's going to totally occlude the IVC eventually. And I mean, I'm not a scientist, I don't know. These were first implanted in 1893, which that would have been an exciting surgery to be a part of. And then they started going transvenous in 1967. Now, newsflash, there's an extremely high incidence of caval occlusion with the vena cava filters. They're supposed to be temporary. What do we use them for? All the stuff we've been talking about. Okay, trauma victims, people that have been in their bed for a long time, pregnant women. What's the stuff the baby swims around in? What's it? Amniotic fluid embolisms. That stuff. I do OB all the time. So we use these a lot. Not so much anymore, but that's what they're used for. We go through the IR in the neck or the groin to deploy these where we want. They don't have to go just in the vena cava. They can go in the iliac arteries. They can go in femoral artery. They go in other places too. These patients usually don't need general anesthesia. They're very, very sick. We're called to help if the patient can't lay still on the table, or if they have a lot of comorbidities, they can't breathe when they're laying flat, or it's a trauma. If it's a trauma, they'll need a little more anesthesia, but most of the time, just a little bit of drugs. The largest risk factor, according to the manufacturers, is that the filter could become completely occluded. In 2000, some of these genius drug manufacturers and medical equipment companies got together and built a permanent IVC filter. And the only way I could see that working would be like if they had like anticoagulant therapy mixed in the steel with little laser beams shooting the clots and disintegrating them as they came towards the heart. And then by 2010, the FDA comes out with a statement that says, these are not good devices. They need to be removed from the market and removed from the patient. They had over 900 reports of adverse events. And by the way, I tried to remove this whole section from my lecture, and I looked at the NCE requirements, which is kind of the stuff that I build my lecture off of to make sure I cover it so you guys have some knowledge when you sit down to take your exam, and the vena cava filter is still on there. Can't believe it. So this is the kind of stuff that happens when you have a vena cava filter. I was looking for some cool pictures, and that last line down there, 70 involved perforation of the IVC. I found a picture of that. It was not super cool, but you could see it sticking out of the IVC. But instead I found this one. And so what we have here, the black arrow is pointing to the filter, the white arrow is pointing to like a 10 centimeter long, totally occluded clot in the IVC, which sucked for that patient. Vascular procedures. I'm sure you guys have done most of these. Angiography, imaging of the vessels, arteriography, measuring just the arterial side of the vessels. Arteriography is cool because it's used for more than like surgical procedures. It identifies outlines of the tumors. If people have AV malformations, it kind of identifies that and allows us to have information, or the surgeon information on how to deal with those things. So, and then once we find out where the clot's at, or whatever we're doing in the vascular procedure, we can do balloon angioplasties, place stents, we can put in catheters. The book did say the further distal you get, the more painful these become. So just because they say, oh, we're just going to pop open the small artery way down here in the left radial area, doesn't mean you can just get away with a tiny amount of medication. Apparently those are more painful than the larger vessels. So we're going to do thrombolytic therapy. The earlier we find this disease, the quicker the intervention, the more success. We can do recombinant tissue plasminogen activator and then neurokinase. There's a few others out there that I hardly ever see. Remember, we're working on like blood clots. And so even if they're small or tiny, there's always an opportunity for one of these blood clots to break off and travel to somewhere that's more dangerous. So if you're doing just like a little embolectomy on an AV fistula, that clot could travel to the heart. And then the next thing you know, you're going to have open heart surgery. So even though these are small clots in extremities, they can be really big deals. Contraindications include active bleeding, pregnancy, allergies to these agents. I'm writing a book, I'm telling y'all. Suspected aortic dissection, and then presence of a non-viable extremity, which goes back to what I was talking about at the very beginning of this lecture. If it's not going to improve the quality of life, we're not going to waste our time, or the patients, more importantly. Embolization therapy, our involvement with these cases are kind of determined by the comorbidities we see with that specific patient. Depending on where in the body we're working, it may be a little propofol or it may be a total general anesthetic. But for most of these cases, sedation should work fine. The goal of embolization therapy is to occlude the veins or the arteries to stop the bleeding. We can do this with coils, which is scary when it's in the brain, or we can do it with glue. They can put alcohol on it, burn it to death. Complications included with this type of therapy is bleeding. As they're putting these chemicals on the clot, the chemicals could spread over to nerve roots in the nearby area. They could actually burn all the way through the artery, creating massive bleeding. So once again, don't take these too lightly. Peripheral vascular access. These cases, no matter how small, are always going to be roller coasters. This is because every single one of these patients have end-stage renal disease, and so nothing goes easy. I remember as a student, the first 3 or 4 of these I did, I thought were awesome because I was like, well, we're just doing this little tiny vascular surgery, and then like our anesthesia record looked like this, and there was all kinds of drugs given, and I was like, that was sweet. No, not so sweet. But according to these pictures over here on the fistula, you can see kind of the big vein that's dilating because of the pressure created by the artery in a fistula. An artery and a vein are connected together, and we use that for dialysis. On the graft, we put a graft in there to connect the vein and the artery. Special considerations for these end-stage renal disease patients: volume status. Okay, have they been MPO? Did they just have dialysis before they came to your operative holding area? Are they due for dialysis in 2 days? Has it, so fluid status is super important. Serum potassium levels are important. Look at their EKG. These guys are going to flip their T waves on you before you could straighten your syringes. Okay, end-stage renal disease patients are very sick. So we'll first talk about the AV grafts. These mature much quicker. It's not instantaneous, but they can start having dialysis on this new graft very quickly because the graft doesn't need time to heal. Usually there's only one operation up front. Okay, that changes down the road. The cons, these don't last long. They're more prone to infections than the fistulas. So if your patient gets an infection in their graft, they're going to come back to the OR, have the graft surgically removed, have some kind of large bore dialysis catheter placed either in their IJ or their subclavian so they can continue to receive dialysis while they're on antibiotics, and then eventually come back to the OR to get a new graft in a different extremity. And most of you guys remember seeing pink bands on your patient on this arm. This arm's, you can't access it for anything. Well, I have a graft over here, or a fistula. So if we start grafting over here, it gets infected, we go over here, we're starting to lose opportunity where we can put IVs in our lines. And these guys are frequent flyers. They'll come back for embolectomies, revisions. Vascular access dysfunction could be due to failure of maturing, excessive bleeding, large volumes of pressure during dialysis, and obviously blood clots. Fistulas pros, this is the best way we can let our patients have dialysis. It creates the largest flow. It's made out of the own patient's blood and tissue, so there's lower infection rates. The cons are that it takes at least 6 weeks before they can do any dialysis, sometimes longer depending on how the healing's going. It may require multiple surgeries up front. Instead of the graft usually only takes one, you may have multiple surgeries up front. The surgeon has to be very finicky when he picks the vein that he's going to connect to the artery because, you guys have all seen those fistulas that are like 1.5 inches raised off the patient's skin and they look like camel humps, So you need to have a vein that's going to eventually look like that, right? Some of these will never ever mature and then we'll have to go to the other side. How do we manage these patients? Roller coasters, every single one of them, no matter how small it is. Always have neosynephrine ready. If they take ACE inhibitors, have vasopressin on the back table. A lot of these patients will have diabetes. They don't come to you with just renal disease, okay? So I don't know if you're taught this in assessment or what, but I remember as a student I was taught if they have diabetes, they're going to have slower emptying, right? So you should RSI them. Well, then I go to the real world, and that's not the case. Like if they're a diabetic, but it's very well controlled, maybe they're just on metformin instead of insulin, they never get heartburn, bowel movements are normal, I probably am not going to automatically RSI that guy. Now, if they're a raging diabetic, blood sugars in 300 or 400s, if we don't cancel the case, I'm going to RSI that person, okay? So they're not an automatic RSI just because they're diabetic. So this is a fun little argument to have that as a student you'll probably lose 100% of the time, but can you use sucks on an end-stage renal disease patient that has a K of 5? Yes? Anybody else? Sorry, yeah? Yeah? Well, you definitely can. You can go up to 5.5. How much does sucks raise our potassium? Right, 0.5. How long does that last? Maybe. Probably not. It's transient. We're looking at 35 to 40 minutes in most people. Just because they have end-stage renal disease doesn't mean that they have a propensity to shoot their potassium any higher than the rest of us. And it doesn't stay higher than any of the rest of us, with the exception of they may need dialysis. Okay? If I have someone come in hot and they're crashing and they have end-stage renal disease and I have to run to the pharmacy to get rocuronium in order to do a rapid intubation, I'm going to grab the sucks. Okay? You can treat sucks. You can treat high potassium too, intraoperatively, right? So that's not a definite no on the potassium in the sucks. But most MDAs will not agree with you because they weren't educated by me. We're always going to fight hypotension, okay? We don't know, like, the fluid shifts that occur with dialysis. When the last time they had dialysis? Have they been MPO? So, like I said, have a neosynephrine drip ready. Have vasopressin ready if they're on any ACE inhibitors. And then these patients, like, if you sneeze on them, they're going to start crashing. Like, they're very fragile. So, like, if you change vent settings, you add a positive pressure setting, the patient's not going to like it and they're going to tank, okay? Obviously, if you put a lot of fluid in, they could tank. Some of our drugs will decrease myocardial function. They'll tank. Some of our drugs do hurt kidneys, so you'll want to stay away from them, like rock, maybe VEC. If they're well-controlled end-stage renal disease, if they don't make urine, if I know their labs, I know exactly when they had dialysis, there's a good chance I'm going to bolus them up front with maybe 500 mils of normal saline. We avoid the lactated bringers because of the potassium in there, but that's like a big no-no for a lot of practitioners. They're like, no, you're going to kill our kidneys. Well, how many of you have had a patient that's been severely dehydrated, they become hypotension, and you push neosynephrine or ephedrine, and nothing happens? All of us. I had that patient yesterday until I didn't. Then I had to give other drugs. But if there's nothing in the tank to squeeze, you're not going to see a change in their blood pressure. So help yourself out. Work in some fluid. A lot of people are going to be scared to do this. Try to say, well, what about just 300 cc's of fluid? I need something in the system. So I'll do that for the healthy end-stage renal patient. These guys are prone to immediately reclot their graft, so they'll come from PACU right back to the OR. Not too frequently, but it does happen. Some people have the good idea of, hey, I want to fill this vasculature. I want to make these guys pee. They're not in Europe. They pee a little bit. I want to look good. I'm going to give them mannitol. Don't ever give mannitol to a volume-depleted patient, okay? That's going to create more kidney damage, increase mortality, increase morbidity. Stick with the lactated bringers. Try to stay around 500. And then this is something that, as a practitioner, I'm pretty ashamed that I don't do on a regular basis, but always chart what the fistula look like and behave like when you drop them off in PACU, even if it wasn't a vascular procedure. Like if you're taking out a gallbladder and they have a fistula or AV graft, make a note, intact, unchanged at baseline. And we just switched to Epic where I work at, and I did a free flap case, and part of the discharge note, I created my own note, but part of the note had AV fistula status. And I was like, I've never noticed that before. So maybe it was, serendipitous because I was just about to talk about it today. So always chart that. Always protect yourself. You can blame it on the circulator. All right, guys, we finished early. Look at that. Yay. So if you have any questions, shoot me an email. Both of these lectures will be on the same test. I'm not sure when that is, a couple weeks away, I guess. My questions have been labeled the easiest, so you guys are going to love me. But seriously, if you have a question, email me so I can clarify it on Blackboard for everybody, okay? Have a good afternoon.